It's a good start, isn't it? Good morning and welcome to the first meeting of this municipal year for the Adult Health and Social Care Policy Committee. My name is Councillor Angela Argenzio and I chair this committee. The meeting today is open to the public and the meeting will be webcast, and the recording will also be available for people to view later through the council's website. It is also possible that Sheffield Live TV will record and rebroadcast this meeting, but I don't think it's the case today. We have not received any public questions and petition from members of the public by the submission deadline. However, we did receive a letter from Mr. Jacob Lewis, and we have a response for him that will be sent, and the response and the letter will be published publicly for other people to see. Please can I request that mobile phones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned for today. If there is an emergency, please take instructions from the town hall staff, and the assembly point is Tudor Square. I'm now going to ask my colleagues to introduce themselves, and I will start with councillors and then go to officers, and I will start on my right.
Thank you, Chair. Sophie Thornton, Councillor for Beechif and Greenhill even, and Deputy Chair of the Policy Committee.
Good morning, Chair. Councillor Gail Smith, and I'm a Mosborough Ward Councillor.
Morning, Councillor Steve Harris, Graves Park Ward.
Morning, Councillor Ruth Melson, Councillor for Crooks and Crosspool Ward and Labour spokesperson for this committee.
Councillor Laura McLean, Councillor for Walkley.
Councillor Martin Phipps, Councillor for City Ward.
Yep, thank you. Sorry about that delay. By my standards, that was fairly smooth handover. Councillor Mick Rooney, newly appointed to this committee, and Councillor for Woodhouse Ward. Thank you.
And officers, please. Alexis.
I'm Alexis Chappell. I'm Strategic Director for Adult Care and Wellbeing.
Sarah Bennett, Assistant Director of Legal Services, here on behalf of the Monitoring Officer.
Rachel Marshall, Principal Democratic Services Officer.
And we have Claire on tech today. The agenda and reports for today's meeting are available on the council website. Paper copies are available at the meeting. They are somewhere at the back there, I think. There is an agenda report pack plus one supplementary pack. Please note that the supplementary pack contains amendments to the minutes from the previous meeting held on the 17th of May and the appointment to the urgency subcommittee item. So we can start. Do we have any apologies?
Not that I'm aware of, Chair, no.
Yeah. Just to confirm, I had Sam Mohammed sent her apologies this morning.
Thank you. So there are exclusion of public and press. There are no exclusion of public and press there this meeting, so we can continue. Declaration of interest. Are there any members that have any declaration of interest? Brilliant. So we get to item 4, which is the minute of the previous meeting, and I just want to clarify, because I asked the question myself, that the minutes of the 16th of March meeting were signed at the AGM on the 17th of May. All the minutes for the March meetings were signed off then in full council. So I will pass on to Sarah to tell us about the minutes and with the supplementary addition. Thank you.
Thank you, Chair. The minutes of the March meeting are provided for information just for the committee because that was their last substantive meeting. In terms of the minutes of the meeting on the 17th of May, can I ask that you ignore the versions in the main agenda pack and refer to the version in the supplementary pack that should be on the table in front of you? Thank you.
So we're looking at the small item rather than what's in the pack. So are members happy with the minutes as they are? That's what we agreed in the AGM. Are there any? Is there any dissent there? So am I okay to actually physically sign the minutes? Apparently I've got to do that now. Thank you. And we'll go to item 5. Sarah, are you going through this one as well? Thank you.
Thank you, Chair. So again, if you can ignore the version of agenda item 5 that's in your main pack and refer to the one in your smaller supplementary pack. This item is seeking approval of the committee to some appointments to subcommittees. There were some vacancies after the meeting on the 17th of May and some changes that have been requested by groups as well. You're also asked to give some delegation to the monitoring officer to appoint subcommittee members in urgency situations where vacancies have arisen and there isn't a meeting available for the committee to appoint to that vacancy. Thank you.
Are members happy with that, with item 5? Brilliant. So we move on to item 6, which we already have discussed. There were no public petitions and questions, and I've already said about the letter, so we can move on to item 7, which is the work programme. Rachel.
Thank you, Chair. In the main agenda pack, the work programme is set out from page 15. If you leaf over to page 16, there are a set of recommendations at the top of that page, which we're asking for approval from this committee. So I will pass back to you, Chair, on that. Thank you.
Thanks, Rachel. I think the only thing that we need to add is for the September meeting, I think we have agreed already in briefings that we will add the Directorate plan to the September meeting. That's the only item I am aware of that we need to add. And also, let's remember that the plan is a working document, so there will be items that can be added or moved depending on what happens. So it's not like set in stone. So if members, in the next few months realise that something needs doing, or just let's have a chat and we can always work on it. Brilliant. Can we move on to item 8, which is recommissioning of community-based domestic abuse support contract. I have 15 minutes set aside for this item, and I'm timing, not the officers, I'm timing the members. Thank you.
Good morning. Thanks for working. Good morning, committee. It's good to be here. So I'm Sam Martin. I'm Head of Commissioning, Vulnerable People and Community Services in the Integrated Commissioning Public Health Service. It's Alison Higgins, who's a Strategic Commissioning Manager for Domestic Abuse Services. So the item, the proposal that we're putting forward to you today is to approve a recommissioning process to let a new contract for the Community Domestic Abuse Service that we have in Sheffield. The reasons behind that are that the current contract that we have, which is since 2019, been delivered by an organisation which is a charity called IDAS, which stands for Independent Domestic Abuse Solutions, I think, or Services. And we're happy with the way they've delivered that service, that there's some detail in the report about the outputs and the amount of delivery that's been provided by that organisation. But due to the contract regulations and procurement regulations and the council standing orders, we need to go through a process of re-tender to just check that that provider and any other provider who are qualified and suitable can bid to deliver that service for another 3 to 5 years. The report sets out, I guess, in some detail, the delivery of that, what that service provides, and the process that we've been through in terms of some consultation work, particularly people that have used the service, about what their experiences were like, and the kind of outputs and outcomes of the services that they've received. And that's generally quite positive, and I think that's testament to the work that IDAS have done in terms of delivery of the contract over the last few years, in particular through the COVID pandemic, I guess, as well, where there were some real challenges, as people have been aware, around domestic abuse increasing, during lockdowns and things like that. So they were very responsive to that. I guess just worth me pointing out to the committee, so this service itself is the community service. So what that provides is the Sheffield helpline. So any of the adverts or posters or bits of information that you might see raising awareness around domestic abuse in the city will have the Sheffield helpline number on it. That's provided by IDAS at the moment and through this contract. And they also provide a range of services to victims, both group work and individual support work for victims of domestic abuse, including supporting victims where they might be going through a court process. So they recruit and train and deliver independent domestic violence advocates, which is a kind of recognised role in that sort of space to supporting victims of domestic abuse. So it's the community service. This service isn't the refuge or the support accommodation services. That's a separate contract that we have, which we relet last year. So this is just the community service that's provided. I'll pause for us in a moment for questions, and just in case Alison wants to add anything. But I guess the other point it'd be worth making to the new committee is this service fits as part of a wider strategy around domestic abuse and violence against women and girls, which we have in the city, which the council is a big leader in, along with other partners like the NHS, the police and local voluntary sector. That strategy is due to be renewed through the course of this year, with a view of kind of agreeing a new strategy from next year. So what we're intending to bring back to this committee and a number of other committees where there's an interest in the autumn is an annual report around the work of that strategy and what's been delivered so far, and then some proposals around how we might develop a new wider strategy, which would include accommodation and support and refuges. So I just thought it's useful as context, because there's a much wider strategy around domestic abuse and violence against women and girls as a part of that. But this particular decision today is just about the recommissioning of the contract for the community service. So I hope that's a useful introduction. I don't know if Alison has anything you'd like to add before we...
Well, just the only thing to add is just that it also fits under our kind of white ribbon accreditation as well that we're doing on violence against women and girls, and we're required to have adequate services as part of that accreditation. So I suppose that it fits in, it's part of that whole piece of work.
Any questions? Councillor Rooney.
Thank you, Chair. It's about where there are children involved who often witness the scenes of violence. Who looks after them? Do we have a specific service, or are they referred to children's safeguarding? Or is there, I'm assuming it's not part of this contract, there is a separate provision for the kids that are often the silent victims in all of this.
Yeah, a really, really good point. The Domestic Abuse Act 2021 recognised children as victims in their own right. So even if they're just witnessing, they're still victims. So it's a really good point. So what we'll expect of this contract is that children's needs are considered, are assessed, and that appropriate referrals are made, as you say, to the Safeguarding Hub, the Children's Safeguarding Hub. The police see a lot of domestic abuse in the city, as you'll be aware, and they refer loads of kids to the Children's Safeguarding Hub every week. And so there's a process within that of triaging and working out who should support the children. But this contract will have a worker in the Safeguarding Hub, as they do now, in order to make sure that that's joined up, and so that the information that they hold about families that they're working with is shared with children's services in an appropriate way. But we have also got a contract with an organisation called Haven, and that actually provide one-to-one support and group work to kids. And we've also got a contract with Door 43 as part of Sheffield Futures to do counselling and therapeutic work with kids. I mean, both those contracts, we could fund them 5 times over easily and not meet the demand, but we have got some services in place, thank goodness.
Thank you. Councillor Milsom.
Thank you, Chair, and thanks very much for the report. I've just got a few little questions. In the recommendations, recommendation 2 says that we'll request a further report. Just wondered what will be the nature of that report, what stage in the process would that be at? Would there be any further opportunity for us to recommend further engagement if we thought it was necessary at that stage, or is that the end report of the process? And so, within that, are you anticipating any significant change in the service offer and delivery model? And one reason why I asked that is because of the figures in 2.7 that says 5,021 calls were received on the helpline against a target of 3,000. This is quite a huge gap. And I mean, it looks impressive that they've taken so many calls, but also there's a huge gap between anticipated need and actual call numbers. So is that a good outcome, the 5,000 against 3,000, or is that is that a horrendous indication of the scale of the problem we're looking at? What's the context around that number, and does it mean that the service needs greater helpline capacity building into to the refresh model with a new higher target, or is that are we still sticking with a target of 3,000 and trying to bring incidents down to that? Because it seems to me that setting a target within this service is a particularly difficult thing to do. How do you know what's out there? And you don't really want to set a target to receive fewer calls if there aren't fewer incidents. So I just wanted to hear a bit more around that. Thanks.
Yeah. Well, the issue about a report on the outcomes and impacts of the recommissioning exercise, that came from a member's briefing. I'm looking at Sarah, because you asked me about it, but it came from a member's briefing, and I can't remember who I got it from. So, but obviously, very happy to report on outcomes as this committee wants, and we could actually bring it back in September, actually, and do that bit of work then. So we're working on doing the kind of targets and outcomes at the moment, but basically there is more need than there is supply. That we haven't got enough money to meet the need, so we are having to think about how we do that. And obviously we can't just say to the provider, just slog yourselves into the ground sort of thing. So we are having to think creatively about that, and that's and we've actually got a soft market test out at the moment. That's gone out through Mercell, the procurement portal, which is about basically saying, asking providers, what they think about sort of solving that conundrum, because it is a conundrum. So what we're thinking at the moment is that we obviously need the front door to be able to take the capacity. So we will have to adjust that, 3,000 up to more like 5,000, because that's actually what they are getting. But in terms of how we then say, well then how do you offer the support after that, we'll be asking them to think about need and risk, and prioritising the kind of service they give on the basis of the highest needs and the highest risk levels. We'll be asking them to do things like develop more online resources, so that somebody who is able to access online resources can access easily useful information about what you can do in Sheffield. But we know a load of people can't do that, so we're not saying that that is the offer. We're saying that for those people who can do that, we'll be saying, why don't you have a look at this stuff first and then come back to us. We also know that people still want emotional support, however competent you are, whatever kind of job you've got, or how well off you are, people still need emotional support. So support groups, trying to get more support groups going, using volunteers to facilitate them. But also the other thing that we're really keen on is community champions. So what we've got to do is continue with our push, really, that domestic abuse is a massive issue in Sheffield. It's a massive issue everywhere, it's not just Sheffield. and therefore we need people in local communities and local community organisations and providers such as you know, home care workers to be able to be skilled up so that they've got some basic understanding in terms of identifying and responding to domestic abuse when they see it. And for some people, I mean, domestic abuse is a big spectrum. For some people, that, you know, it might not be that they need a lot of support, or they've got resources that they can help themselves with, or they've got really, really good and effective networks of family and friends who can help them. For other people, they're going to need loads more support, and that partly depends on people's individual needs. It partly depends on the nature of the perpetrator, to be honest, because that's the kind of wild card that nobody can control, as it were. So having community champions who can sort of offer that initial support and then refer the people that need to be referred for targeted support is what we're hoping to get to. But, you know, it's easier said than done, but that's what we're going to work towards. But I think this is where it fits in with that wider issue around White Ribbon and all that other work that we're doing, in that we've got to do prevention stuff. And this service can't do that because it's dealing with all that demand. So we've got to really make the White Ribbon accreditation work for us as a city, because what we need to do is prevention. You know, we need to stop this happening in the first place, don't we? And again, that's not a quick fix. It's something that we need to work on together over a, you know, period of time.
Thank you. Quickly, please.
Thanks, Chair. Sorry. I think, I mean, clearly there's a need for that capacity then, isn't there? So I wondered what the response has been from the Office of the Police and Crime Commissioner since they co-fund part of this, what their response has been to the very much higher demand over the target set, and have you asked for more funding from the PCC, and what's been the response to that?
Sorry, I haven't actually written a formal letter to them, but they are part of our processes and they are a close partner that we work with. What we are doing with them is working with very closely on getting the central government funding into the city. So you'll have seen that we've got a sort of a main pot that we know is in place. And then we've got next year, we've got some money that's come in from the Ministry of Justice that's actually come through the OPCC that we're going to add into the first year of the contract. And then we've sort of put another amount in there, because what we want to do is to be able to make, to be able to get extra central government funding in, should it come in. Obviously, we're touching wood and hoping that it's going to come in, and we work. Mike keeps going. So it's a really close relationship with the OPCC. Their representative sits on our strategic board and chairs our joint commissioning subgroup of our strategic board. So we work like that, basically. And I mean, they know exactly what the pressures are. They've seen this paper. You know, they haven't formally written to them and said, can you give us some more money? But I know that they are working really closely with us, and that if there was any more money, they'd be giving it to us.
Thank you. I'm just conscious of time. Got Councillor Phipps, and then I've got two more.
Thank you, Chair, and thank you for the report. It's good to note in it that partners value the service and believe it's of good quality. I think that's really good to hear. Just a couple of quick questions. I saw on the statistic about IDAS supporting 69% of victim survivors to exit the service in a planned way, and there was a target of 60%. That's good that IDAS exceeding the target and supporting more than the target. I was just wondering why the target was 60%, which from like a layman perspective seems quite low, but there might be legitimate reasons for that, so I just wanted to understand that a bit more. And then kind of following on from Ruth's questions and your response, Alison, what are we doing to prevent and lower domestic abuse levels? I know in the report there's a programme for addressing domestic support, like talking to perpetrators and trying to stop it continuing, but what are we doing on a more general basis to prevent and lower domestic abuse levels in line with our commitment to addressing violence against women and girls and the White Ribbon campaign accreditation? Thank you.
If I just briefly come in on the second question there, Councillor. So I guess that when we bring back a piece in the autumn around the wider strategy, I think as Alison says, probably talk a lot more then about prevention and how do we, as a city, not just the council but the other partners as well, really kind of get into that preventative space. I mean, there's a lot of stuff that already happens. So, I mean, I guess some of the stuff that IDAS do as part of the contract is promotion and awareness raising, and the team, Alison and team, do an awful lot of that stuff as well through, you know, World Domestic Abuse Day, White Ribbon Day, and those kind of things. So we do that as a council. So there's a whole bunch of stuff going on there, and I think some of the, you've picked up on things like the perpetrator programme work, which is kind of one of those really big developments over the last sort of couple of years, where we're really, you know, essentially this is. We all need to support victims. We acknowledge we need to do that, but actually it's the perpetrator's behaviour that needs to change that's at the core of this the whole sort of epidemic, I guess, across society. So that's where I guess we anticipate trying to invest more resources over time to really get to that point. Again, White Ribbon campaign is focused on men and boys changing their behaviour and being champions and calling stuff out when their friends and family say or do things. So it's about sort of turning it away. It's not just about the victims, but also about perpetrators. Is there anything you'd want to add?
Yeah, well, just to follow on from that, we are hopefully doing some more work with schools. Got a meeting next week, Kevin Strawn, who's one of the school's leads, about possibly organising a conference with schools looking at all these issues. So, I mean, you know, it's a massive area getting into schools, but also Sheffield's got quite a good track record, because we've got the student wellbeing resource that was developed with Learn Sheffield a few years ago that's currently being updated, which is about providing sort of good practice resources on all of this stuff, on healthy relationships, etc. But also working with youth services. One of the roles in this contract is going to be co-located with the community youth teams. So, you know, getting in there and doing that early intervention with young people. We've just done some training this year, Escape the Trap training, which is training the trainers around healthy relationships, which youth work people were on. In terms of the 60% planned exits, I think the issue is that a lot of people engage with support and then might kind of walk away from it without doing it in a planned way, because they kind of have got what they wanted and they then disappear. But then the other thing is that a lot of people, it's quite hard to engage people in support, and it's quite hard to keep them engaged in support. And that could be because they've got all sorts of other things going on in their lives, and or it can be the influence of the perpetrator. So I think it's a realistic target, but we're very happy that they've been exceeding it. But it's, you know, I mean, I'm sure every service that tries to engage people in support knows that it's not always easy to do that. And I think when it's such a difficult issue as domestic abuse, there's a lot of shame and stigma around it. And there's also, as I say, the actions of the perpetrator, which means that not everybody stays engaged.
Thank you. We're already over time, and I've got Councillor Erris, Councillor Thornton. Yeah, and Councillor.
Can you tell me, do you work with the Youth Council?
Yes or no, please?
Not regularly, but we have done, and it's something I definitely want to do as part of the White Ribbon Plan. But we're just so plug for the White Ribbon Plan. We're just trying to get that pushed through so that we can get it signed off in the autumn. So, and that will be hopefully part of that plan.
Thank you. Thank you for the report. I've got a couple of questions on page 46, so I'll ask them first, and then I've got another one. So I'm looking at paragraph 4.2.5, where it gives the breakdown of the available funds. And I see that from that, it talks about the Sheffield City Council's cash limit being 677,557. When it talks about Sheffield City Council cash limit, is that adult care, or is that adult care Directorate, or is that public health?
Sorry, it's adult care, not public
It's
health.
not public health grant.
Right, okay. Then looking at the breakdown, I see that where the table that you've outlined there, the total SCC fund currently is 46% of the, so 677 is 46%. So if we don't get the continued funding after March 2025, then our proportion of the total funding goes up 61% if we don't get the ICB and MOI funding on other grants. Why is it not worked out on a pro rata basis?
Yeah, good question.
There's no specific reason for that, I guess, Councillor. Historically, what we've done is develop the budgets and the services based on what we've had available and what we can kind of get out of the partners in terms of, for example, OPCC. But sometimes their funding, I guess, like the councils, is based on income that they've got from government that they might not always have. So it's a bit of a kind of movable feast. Every time we come around the commissioning cycle, we have to relook at it again. There's probably not a straightforward answer to that one, but it should be a really good suggestion.
Okay, thanks for that. In fact, my other question on this was on paragraph 6.2 on page 48, where it talks about recommissioning the contract through a process of co-production. I welcome co-production, but that's a bit of a generalised term. Can you elaborate on it sounds good, but who's the co-production with? Thank you.
So the Changing Futures programme that you might have heard of, which is a programme working with people with multiple disadvantage. And as part of that programme, they've been contracting with South Yorkshire Housing Association to develop a co-production model. So what South Yorkshire Housing Association has done is recruited co-production associates who are people who've experienced various types of disadvantage and worked with them and trained them to be involved in various projects. So for us, a group of women who've experienced domestic abuse have worked with us to develop the consultation that we've done as part of this project. That's the first thing they've done. We will be talking to them about the specification, and we'll be talking to them about the next bit of the process, the method statement and the evaluation. But what they've done initially is they've worked with my colleagues to design the questions for the consultation, and then they've gone round to different meetings, community groups, things like that, to talk to the public, people who might have used services, staff who work in services, to talk about what people want from the service, from the domestic abuse service. So, and it's been really positive. So, going to speak to, domestic abuse staff about how the project works and what they think should be in the new specification when it's people with lived experience doing that has been quite an interesting thing. But they've also been to, various different groups, so user groups. So there's still a few more to do. I know that they're going to see users of Ashiana, the BME service, next week or the week after. There's still, it's still ongoing, but they've done a big chunk of it, and so far it's been really, really useful. Not all the comments are positive, and not all the comments are about the actual service. They've been about the police, they've been about housing, they've been about health. So it's actually a real kind of gold mine of information we've got back that we're going to be able to use as we go forward, not just for this contract, but for the strategy and the other work we're doing.
Councillor Thornton, we have nearly 10 minutes over time for this item, so can we be a bit sharper?
Thank you, Chair. I'll try my best, and thank you for your report. I did have two questions, but I think one of them has been addressed on preventative measures, and I'm quite reassured, Sam, by what you've said about the flipping the script and the focus onto the actual perpetrators, because I think quite a lot of the time, as women and girls, we're told that it's our responsibility almost to get ourselves out of situations and not the responsibility of the people who are putting us in those situations. So I'm reassured by that, and I'd appreciate, Alison, you mentioned about the healthy relationships training sessions in schools as well. I'd appreciate a more detailed report back at the next report on that, please, if that's possible. One thing that I was doing a bit of the background reading that stood out to me was actually the economic impact of domestic abuse in terms of lost economic output and cost of service. I think it was said in 2017 it was a £34,000 per victim annually economic impact of domestic abuse, and taking into account the nearly 24,000 potential victims in the city, that's potentially enormous. And not only does that, as we can all sing from the same hymn sheet on how that prevents people from resuming safe and independent lives, the impact on our wider economy means we'll have less money to reinvest in preventing stuff like this in the future. So I appreciate this is a wider piece of government research, but is there going to be any monitoring or modelling done around this as the service is recommissioned, just to show the impact on that respect?
I think it's a great idea, and I think you're right, yeah. I mean, there's a whole range of impacts. You said domestic abuse just has this kind of horrible impact across all the society in so many different ways, not just on individuals, which is really sort of devastating for. But I guess in terms of this contract, I don't think we're planning to do any particular analysis of sort of economic impact of the delivery of the contract. There's a part of me which is thinking, as Commissioner now, that might be quite a difficult piece of work. Not that it wouldn't be useful, but I think it will be a useful thing to return to as part of our wider strategy. Because I think we're talking about a really important dimension of that. The impact of this. It's not just about victims and individual families and individuals, but that wider society as a whole. So I think we'll take that one away and go, okay, keep that in mind when we return to the themes of what our future strategy might look like, because it might be one that we've not paid enough attention to.
Brilliant, thank you.
Thank you. Thanks, Sam and Alison, for presenting. I'm going to move on to the recommendations. There are two. The first one is to approve the recommendation via the recommission via contract with an external provider of domestic abuse community-based support as outlined in the report. And the second is requested a report on outcomes and impact on the recommissioning exercises brought back to committee. I think Alison mentioned September. We'll have to see if it fits in with the work programme, but let's say September or possibly November, depending on how it fits in and timings. It may give you a bit more leeway. Is everybody happy with that? Is there any dissent? Can we agree on those? Brilliant. You're happy with that? Good. So we're going on to the next item. That is item 9. Hospital discharge model and improvement plan. And I am going to be really strict about this. So could members shorten their questions and help us to finish on time, please? Thank you.
So I think Victor Beasley, I'm Alex Chappell, Strategic Director for Adult Care and Wellbeing.
Morning, colleagues. I'm Ian Atkinson, Deputy Place Director within the Sheffield Place team of NHS South Yorkshire Integrated Care Board. Nice to meet you.
Yeah. So I'm going to start and give an opening, and then I'm going to hand over to Ian. And so what I want to start off by is saying that this is about people. And one of the things that around hospital discharge, often people talk about beds and talk about what does this mean in terms of delays. For me, what I think about this is about people. Is ultimately, this is whether you be an older adult or whether you be a person who is with a learning disability or who's autistic or experiencing mental health, being admitted to hospital and going through the period of being in hospital and coming out of hospital can be one of the most challenging episodes in a person's life. And, for anybody who has a family member or carer or who have went through that themselves, this could be, it could be a very challenging time for anybody. And so for me, what I want to do is make discharge personal. As we often talk about that in terms of safeguarding, for me we've translated that in terms of actually discharge. So that from a point of view of what we do is we start to talk about this in terms of the outcomes and the impact that we're having on people and their lives. So that experience should be as positive and should be as smooth as it should be. And what we're trying to do to get to that point is to make sure that we have timely discharge from hospital, which is the content of the paper and that new model. But the same token is start to change how we collect our data within adult care, so that our data is not just about how many people will manage to discharge from hospital in a timely way. It's also about the outcomes and the impact we've had on that individual. So that, if you're a family member or carer, what I want people to be saying in Sheffield is actually, you know what, I've had a good experience of this. and that I felt supported through this whole journey. If you're the individual, I want you to be able to say whether you have some capacity or not, is to be able to say, is actually I felt supported and I've got the good advice when I've needed it at the right time. And that's what I want us to be in that position to say. And what in the paper describes in the appendix, which Ian's going to talk to, in a sense, is the mechanisms by how we get to that point, so that we ultimately could deliver the very best for the people of Sheffield. And that's very much in line with our strategy, which is very much living the life that you want to live. Our adult care strategy set out an ambition to enable people to live that independent life at home. This is basically a one key part of that strategy. So on that note, I'm going to hand over to Ian, who's doing all the legwork, and I'm going to say this behind the scenes to make this all so.
It's a collective effort, isn't it? So
yeah.
Thanks, Alexis. Thank you, Chair. So I won't go through the paper line by line, all the slides. I'll be quite to the point on this, expecting colleagues have read the detail. But I think before we get into the detail, we should acknowledge that this is a really challenging agenda across partners. It's a national challenge. It is really challenging. And when we describe a new plan and a vision and a strategy, we sometimes forget about all the staff that are working tirelessly across our services at the moment just to try to improve discharge day in, day out. So I just want to start with that, if I could, Chair. In terms of our background in this space, as I mentioned, it is a national issue. It's a national issue across acute discharge out of our acute hospitals. It's an issue within mental health and in learning disability. And we're coming together collectively to really focus down on that as it's an all-system issue for us. So we really want to just make that point today. In terms of this element of presentation, it's predominantly around the acute pathways of care that we are trying to improve in this space. There is other work taking place and at pace around mental health and learning disability, and again, members can receive that accordingly. In our Sheffield space, we are seen as one of the challenged areas nationally. It is an area that has to have priority. We need to improve in this space in terms of numbers of people waiting to be discharged and the pathways they go down. In terms of pathways of care coming out of hospital, just want to mention it is in the paper. We categorise patients in 4 areas in this space. We describe pathway 0, and these are cohorts of patients that might have had a short stay in the hospital and then can just go home with no additional support from wider care and partners. And then we have pathways 1, 2 and 3, whereby within this setting, patients will require additional support. So that might be home care, it may be care home, it may be intermediate care, it may be bespoke packages of care. And this is the real focus of this discussion today around how we want to improve that element. There is a lot of work happening within our hospital settings around pathway 0 as well, in terms of that. So just important to note that, if we can, colleagues, if that didn't come through in the paper. In terms of our collective challenge, at any one time at the moment, on average, we've got about 18% of patients that are currently in a hospital setting within the Sheffield space that are deemed as no criteria to reside, or actually that they are fit to be out of that hospital. So that's about 240 patients, of which 50% of those are in pathway 0 and the other 50% are in pathways 1, 2 and 3. So it just gives you some context in terms of the numbers of patients. When you're working on a bed base in our system of around 1,450 beds, reminding colleagues it's one of the most biggest hospitals in the country, you can see there's a fair amount of capacity, but what we are, as Alexa says, what we're really trying to double down on is that quality discharge, it's a timely discharge. We miss opportunities to optimise care and ensure that those patients on the discharge pathways go back to their originating place of residence, and that's our primary goal. So in terms of our challenge and our vision, we have set out a 6-step plan. We've tried to simplify that. I can see it on the slide there. I think the kind of cornerstone of this is 2 things. We want to move to a home-first model. We want to be assessing people in their home environment or their place of residence. We don't want to be undertaking assessments in that hospital space. We know we can have better outcomes for patients if we do that. In order to facilitate that, there's a vision that I'll talk you through in a second, but we do need to focus on removing the current queue. We've got to get this queue that's in our hospital system down, and we'll talk about that in a second around how we do that. We must simplify our processes. We've got lots of destination points for people on pathways at the moment, and we're really keen to simplify our hospital processes, our out-of-hospital processes. We want to bring services together in that community setting to create community reception services that know that what patients are on the caseload coming out, well in advance of them coming out, and they actually moved to a pull model. So we start to pull patients out of the hospital as opposed to a current view where we're kind of pushing on services. So we've got a better line of sight around that. We need to build home care capacity. I've not been around Sheffield that long in this role, but I know you're undertaking tender process on home care, and that is a crucial part of our architecture and discussion. We need to maintain independence wherever possible. So that's at the heart of the thinking. We create too much dependence on our pathways at the moment. I think that's really well acknowledged across the Sheffield place. Linked to that, when we have got package of care for people within those home settings, we need to review them in a more timely basis than we do now. Colleagues across social care have done some fantastic work over the winter period around reviewing patients, and that's given us some really good evidence actually to build our model on. And again, thank you to colleagues that have worked in partnership to do that. But we want to move that to scale. We've got to move that at scale so that we're getting people reviewed on care home packages. The final point on vision, it's okay doing this, but this is not a one partner solves this problem. It has to be done in partnership. When you look at all the best evidence out there, it's when you bring the system together. And I think we have done that, and we're demonstrating that as part of the work that we're now doing across the Sheffield place. And it's really kind of positive, the dialogue that we're getting into, but it is a challenging dialogue, so we don't walk past those challenges. So just a couple of take-home points on the challenge. One is we've got to remove the queue. We've got to really move down that as we move through into trying to get as much out in that kind of list of patients before November, before we get into another very challenging winter. It will take time, this programme. I think we all acknowledge that we want some quick wins. We want to improve pathways, but this won't be an overnight job, so we just have to reflect on that. And then finally, if I can, Chair, I think in my lens, I'm sure it's the same for you, Alexis, this is probably one of the only areas at the minute where we have got ring-fence allocations through our Better Care Fund, just short of £7 million coming through this year. That's a split fund, but obviously we bring it together. So we are articulating within the paper how we expect to allocate that funding in, both to put the cornerstones of a new model in, but also bridges over what will be another challenging winter. So I think that's all I wanted to say today, Chair. I hope that's the level of information you require. I'm happy to take any questions. Thank you.
I have Councillor Rooney and then Councillor Smith.
Thank you, Chair. I mean, this sounds like a move from treatment in an acute setting to a primary care nearer to home setting that's been spoken about for a very long time. And it also sounds a lot like the initiative that used to be Right First Time, I think, as well, with being rebranded. Obviously, it's the right thing to do. I've just got a question about where, for example, someone comes out of an acute setting, who's monitoring their medical needs while they're at home being sort of assessed for what is the right package for them to stay at home? Who is it, the GP, or is it an outreach service from the hospital? Because if it's the GP, I can imagine, has anybody, people who have tried to get into a GP's surgery these days, I can imagine them jumping up and down and screaming and shouting, saying, "Whoa, we're busy enough already, thank you very much." And are we also talking about moving people out of, say, for example, mental health wards, not just wards where people are physically unwell? So we are talking about that. So then when they move out, one of the fears that I've got is that there won't be the expertise in the community setting to deal with people who are not just physically unwell, but mentally unwell as well, or have a substance misuse issue. So I would have I'm saying this is the right thing to do. I don't think there's any doubt about that. But it's all well and good, but we do need not just numbers of people, but properly trained people to deal with this sort of issue. And there also has to be a transfer of resources from the payment by results system into primary care. Otherwise, you're just going to fall at the first hurdle unless there's a flow of finance from the acute hospitals to to primary care. And to me, the easiest and most sensible way of doing that would be to suspend, which is, I believe, still allowable, payment by results.
Thanks, Councillor. Can I just come back on those 2 points then, Alexa, if you want to come in? In terms of the model, one of the cornerstones is enhancing. So we've got a lot of community services out there that are wrapping care around patients already, Councillor. What we're describing in the community reception model is that they will pull those patients out, but then they will have a joint oversight of those patients and put the appropriate level of care in, both from a home care perspective, but then the ability to review in a timely manner. Now, primary care may play a role in that, which is part of core GP services, but it's not the GP that is that coordinator. There may be in certain circumstances, but predominantly it's our community provision that is in there that we will then also enhance with the work that we're doing in this space. In terms of the mental health aspect, it is absolutely our intention to drive down. At any one time, I think there's about 22 to 23 patients on average that are in a health and care trust bed that could be out in our community settings. So again, we will be describing what our plans are for those shortly, probably a similar type of model that we're driving at the moment. Quite a lot of that is innovative housing and care packages and support around those patients. So again, we'll be looking into that space as well. I don't know if you want to add Alexa, thanks.
So, I was going to say, I think your questions are absolutely on for the money. I'm going to say that. So, we've got one of the really good questions. I think that the first part of this is about how do we support people in the community. What you've got, for me, I always think about it is when people go into hospital, we all have a GP when they go into hospital, and then they'll go into hospital and they'll come back out to the same, working with the same GP. So it's kind of thinking about, in some ways, what we're trying to do with this model is essentially enable people to go home, back to their own home environment, so that they have that same supports. What we are trying to do, and this links to the adult care future design that was agreed at committee in November last year, is about how do we work in a far more joined up way between our community services and adult care, primary care services, and also your district nursing services and your allied health professionals, so that from the point of view of the individual, is that what they should experience in some ways more of this is about as an episode when you go into hospital, as one episode, as opposed to this being about the entirety of their experience, if that makes sense. And what we'd hope to see is by both this model and our wider work around our community design starts to come together. And so that two things, what I really would like to see is happening, is that we actually prevent people from going into hospital in the first place, which is the key thing. And particularly where you've got falls or where you've got people who are frail due to medication issues, which you're kind of alluding to. And then the second bit then is when people then come home from hospital, is that we have that wraparound support in place. You're absolutely right about the training as well for staff, and what we recognise is that particularly, and we've actually got some of our teams actually in committee today, particularly our home care services, both internal and commission, often work with people with a wide variety of issues. And one of the key commitments we've made as part of our new home care design and our internal services is to ensure that our staff have a full kind of care development and support, so that no matter what the issues that the person has, we're able to provide that really holistic service. Because actually it's often your care services who are the people who are actually working with everybody. And so that's why we want to make sure they're invested, and we've really taken that as part of this model. The second bit in terms of kind of mental health is that I'm actually ready to go and chair. It was one of the briefing sessions we've had is a South Yorkshire group that's going to focus on housing with support and care. And last November, what was agreed at committee was a market shaping statement that focused around housing with care, and that was done as a collaborative across South Yorkshire. And one of the key things it looked at was actually how do we develop more type of accommodation such as support living, extra care with housing providers, so that people don't have to be placed out of area. And secondly, that people could live really independently at home. And we unpack the mental health discharge issues, which have been around for the last couple of years, is it generally is down to two or three main issues. Number one is about sufficiency of home care, which will be addressed through this model and the work that we're doing here. And then secondly, it's about the housing with accommodation. And what I hope is through that group, we'll start to really get into that work. What is really helpful, and I can say this, is as of today, we've done a couple of tests of changes over the last year to work in a different way, and actually health colleagues funded a reconfiguration of a couple of properties which then led to a person coming back from out of area, back to Sheffield, and who's now living, they're now living really good independent lives, and it's wonderful to see the changes that's happening from a person's point of view. And these individuals had been in long stay hospital, and we just worked very differently. So actually what we're going to do is build upon that to actually a more grander scale, and that's what I'm going to be leading across South Yorkshire. And what's very nice is health colleagues have given me access to all their budget, which is great, so that's going to be great. So we have to go and take that forward. Ian's probably now panicking at what that actually means. So we have, but ultimately I think that will help us to go in, I think, work in a very different way and going forward. So hopefully that helps answer your question.
Thank you. Sorry to interrupt. I'm going to take two questions together. Can members be really succinct in their questions? So I've got Councillor Smith and Councillor Milson, and then we'll get the response to both of them together, if that is okay.
So thank you for this report, and I want to echo what Councillor Rooney said, because we've been talking about this for many decades, not a few years. And I speak really as a retired health professional and a family carer on this, which I'm very passionate about. We have seen, I mean, I have experienced all sides of this, and in a personal capacity. And I do think that the care workers in the community that work for private companies, this has always been a bugbear for me, because I don't believe they're properly trained. Most of them do an amazing job, but they could do so much more. They could help more in an emergency situation. And I think that you need to get the companies around the table and talk about training. Also, I believe that the biggest problem is preventing people entering into hospital in the first place. Now, paramedics do an amazing job with that, but are they part of your consultation? Because do they need to have the ability to bring in a service in the community? Because often I believe that would be a quicker way of getting that person that help, because your GP, it might be at middle at night or whatever, but your GP can take that bit longer. So I'm just asking if those are the things that you may consider. Thank you.
Can I have Councillor Milson, and then we'll have...
Thank you, Chair. Thank you for all the work that's already gone into reviewing hospital discharge. It's raised I think some really key questions around this, which other members have already touched on. It's obviously such a key pillar of the wider strategies for enabling healthier lives in Sheffield. So additional funding for improving hospital discharge is obviously really welcome, but as you've pointed out, there's no counterpart national investment in helping people keep well and avoid going into hospital in the first place, as Councillor Smith has mentioned. What do you believe to be the impact of that lower financial resource on the prevention and health creation side? And what kinds of things would we want to do with extra funding for prevention? And what kind of challenge have you, Adult Social Care or the Integrated Care Board, put to the Department of Health and Social Care on what is, I think, really a self-limiting and non-joined up national strategy? And I think there's a further point here about the real need for quality social housing, but that's probably a whole bigger discussion for elsewhere, isn't it?
So I'm going to come in first, and then I'll hand over to Ian. So as of different points, I completely agree with both about the length of time. And one of the commitments when I came into post, actually just about 2.5 years ago now, was saying we wanted to get to a way in which we worked in partnership with colleagues to get to a better way of working. And these things take time, you know, particularly because it was during the pandemic. But one of the key things I think was really helpful last year was we did a test of change in partnership with health colleagues, in which we call 1600 hours. And this was approved at committee as a way of looking at differently about how we worked around discharge. And that has actually laid the foundations for the model for today and how we sort of go forward, along with the relationships across, you know, with colleagues across with health and the voluntary sector within this. So what is coming today is in some ways is a culmination of a good couple of years of relationship building and kind of work that's been undertaken. to get to this point, because I was really clear we needed to get to a better position from the point of view of family members and individuals across Sheffield. And a couple of key points here is in terms of carers. One of the things that we've done is we've got a really good partnership with Sheffield Carer Centre, and actually what we've got now is our teams locally through our internal home care teams as well as our care assessment teams are actually increasing the number of referrals to the carer centre so that family members of carers are being identified and supported, because that was one of our key commitments as part of that, and that's going to be one of the key data that we collect is actually about our support to unpaid carers. Secondly, in terms of the training to staff, is one of the key things as part of our new home care delivery model is developing a provider collaborative basically between our internal home care services and our commissioned home care services, in which we really look at, for me, as a DAS, I have responsibility for both your internal and commissioned. And so for me, whether services are provided in the council or out with, I still have the same responsibility in a nutshell. So what I want to do, what we're doing through this new provider collaborative is making sure, and through our new home care contract, is making sure that no matter whether you work in a commission service or an internal, you have exactly the same learning and development and training for staff. And actually over the last 2 weeks, what I was in meetings with was Sheffield College, which I'm just going to stay here to is about how we set up a health and care academy for Sheffield, about so that our care workers have absolutely the best start. And I'm going to say from a personal point of view, I actually started as a home carer when I was 17.5-year-old. And I think there is something about saying to home care staff in the city, even if you come in at age 18, you can end up being a director. You know, there's something about the career pathways for staff and saying that actually we need to value this workforce. This also links into what we've talked previously at committee about is our workforce strategy and the pay rates to staff. And one of the key commitments I've given to committee is we'll come back to committee, I think it's in December, with an outcome that says actually how we deliver upon the Unison and G&B charters for our care staff in the city. And we will be the leaders, I think, across England in doing that, because I've been very much wanting us to show that we are actually doing the best for our home care staff in the city, because all that impacts on the best quality care that we can do. The third bit is around prevention of admission. We're already doing some tests of changes around prevention of admission, because one of the key things that struck me is the funding is not there in terms of prevention, which I have raised nationally in my own right, but I could work with members out with this about actually how do we perhaps escalate that in different contexts, in different ways about the funding, because what we have got is a couple of tests of change which I would like to go bolder on. Number one is around our citywide care alarms. We are working with Yorkshire Ambulance Service just now around tests of changes, and already that's been really successful and working in a very different way to look at prevention of falls. And then secondly, we're working with the pharmacy services, and we've now got a joint pharmacy post, particularly working on medication management, because that's another reason why sometimes people end up in hospital. So I think for me, these are two key practical ways in which we start to get into how do we stop people going in the first place. In terms of mental health, my colleagues in the Sheffield Health and Care Trust now have really started to focus on this question rather from the discharge question of how do we discharge people from acute mental health hospital to actually more the question is how do we prevent people going in the first place. So that's been our perspective. And one of the key bits of work that we're going to do through this work is look at our buildings and our joint developments to look at how do we, as the next phase of this, think about our avoidance of crisis admission, which I think is, as I mean, that is one of the key kind of issues that we have behind us. And then the fourth thing for me is just to respond to questions around the funding around this. We have the Integrated Care Partnership, and there's a working group around that, and the whole strategy around the Integrated Care Partnership, which is South Yorkshire wide, is particularly around prevention. And one of the key things I've certainly put onto that table is let's think about prevention, not just about your wider whole-scale prevention. Let's think about this as straightforward as actually, well, how do we prevent people from going into hospital in the first place? And then what is the pressures that we need to think nationally about that? So I will take that as a job card from today to continue to escalate that.
Can I just make a couple of extra, I won't take too long, just on the comments around admission avoidance with YAS. Councillor Smith is doing lots of work in that space at the moment, so we all know the challenges at the front door of A&E. So wherever possible, signposting into other services. The city-wide falls service is an excellent example of that. Now it's on 24/7, within a month that's been held up as best practice in the Yorkshire, but it's fantastic. But there's other pathways that YAS will increase in, and that is a space where we're in regular dialogue around. Wherever possible, YAS will see and treat, hear and treat, either over the phone, or we'll try and push the patient in a constructive way into our local services to avoid conveyance. We're probably really well performing in that space, actually. So if you want some more information outside the meeting, I can share that. In terms of the funding question, what I'd say is healthcare is an expensive business, isn't it? That we consume a lot of our place-based allocation in our acute setting. There is absolutely a joint commitment across partners to have the dialogue of if we can reduce our spend in this space, where we're going to put it in prevention. So it's not a them and us discussion, and that's the benefit of the strong partnership. So we'll all have a perspective where is there ever enough money type discussion, but actually we do spend significant amounts on healthcare in Sheffield, and we are committed to the discussion around where we can spend it in the right pathways of care. So a bit of assurance for you there, Councillor Wilson. Those discussions are live and challenging, but very constructive actually. So thank you.
Thank you. Can I have Councillor Aris and Thornton ask their question? Can you be very brief, because we've taken twice as much time on this item so far.
Yeah, it's a similar vein. A lot of the point I was going to make, the question I was going to put, has sort of partly been answered. But in terms of the community capacity, I'm just wondering what the D2A model can learn from the experience, sort of attracting the specialisms to community services, which was specific to that particular thing that came to health scrutiny, but just in the wider sense in other areas, I guess.
So I could come in this one. So,
sorry, Alexa, can I just get...
Sorry, thank you, Chair. So I just wanted to ask a couple of quick questions. First, on the community reception service, can you just talk us through, actually, I think it'd be beneficial for members cross committee, actually what that looks like in practice and how that looks tangibly on the ground. And from speaking to Liberal Democrat colleagues who have had careers in health or still work in health, they're just wanting some reassurance on where health and care come together in areas like physiotherapy, where we don't necessarily have the provision in the city that we would like. Will support such as physiotherapy be maintained in this model, and how will it be maintained?
So apologies, I didn't realise there were two questions, so apologies. So I'm going to do part one, and I think Ian's going to do the next part. In terms of the learning from First Hill, there was a lot of good learning from First Hill in the situation, because I was involved in different capacities around that situation. And I think that, for me, I think the learning from First Hill was about the prevention of admission in the first place. One of the key things that struck me from individuals that were in First Hill at the time, they'd been in long stay hospital for a long time. And the question for me was about actually what was the right type of accommodation that we need to have for individuals to live that independent life, which is where the test of changes that I mentioned had come from. And when there was a position in which we needed to move people from First Hill Rise to different places, what became really clear about was A, the availability of resource, and B, the right type of resource for people with really complex needs. So this is where the South Yorkshire group that I mentioned actually kind of came from, actually some of that learning from First Hill Rise, but also other circumstances, and how we really work with particularly housing providers across South Yorkshire to develop different kind of models of care, so that people have the right type of support, the right type of accommodation, and the right type of sensory and adaptations as well, so that people could live that independent life and not end up in a particular situation where they're in long stay hospital in the first place, which to me is one of the key things. And I think in terms of the discharge to assess model, coming to that, I think it actually comes back to some of the questions that came earlier on, is about the learning and development for our kind of, particularly our care workforce. And our care workforce are the workforce who end up being involved in pretty much every situation, whether it be crisis or planned. And for me, I think the key thing is actually from us is about making sure that we have that robust training programme in place so that we can be adaptable to different people's circumstances, but also do it within the requirements set out by regulation and by law. So hopefully that's kind of helpful in terms of that aspect. And then in particularly the kind of aspect around the community reception service and the partnership working, Ian's going to come into that one in a second, but one of the key things I would say that is probably over the last couple of years, there's been a lot of really good partnership working, particularly with colleagues in health, around how we work jointly around discharge and the community. And the developments that we're doing around the care and wellbeing, around home care and discharge to assessors, we came out of a lot of conversations on how we do things differently together. And it's that partnership, I think, that will help us to not only develop a community reception service and do something really good and well jointly, but make it sustainable. My take on, sort of come back to some questions earlier on, coming into Sheffield, was that I think there's been a lot of models in the past, but the challenge is that they haven't been sustainable, and then it's left adult care with a number of financial pressures, which is what we've had to address over the last couple of years. All these things kind of go hand in glove together. What we've done with this model is start to talk about exactly what Ian's talking about, is that kind of question around how do we shift funding, but how do we resource up your home care services so that the pressure's not all in adult care, for want of a better word, is a system-wide response to that, so we make this a sustainable long-term model which everybody's working from the same mindset to get the best outcomes for people, basically. So, Ian.
Yeah, thanks, Alexis. On community reception, I think, please don't think we're trying to reinvent the wheel in this space. We've already got a lot of services coordinating care out of hospital, but what we want to try to move to is a view of pulling those patients, so we've got a better line of sight on them when they're in the hospital setting. So we probably know at day one in the hospital when we think they may come out, and coordinating that care in a much more joined up way. As well as doing that, is going back to Councillor Rooney's point of when patients are then back in their home, we've got a really good clear line of sight on their packages of care in the first instance, and then a view of reviewing that care also. So that's the kind of theory on the model. Colleagues, most of them in the corner there, are working up that model at the moment around how that will look, but we'll get to that really quite quickly. On physiotherapy, apologies, Councillor Thornton, I don't know the detail of the perception of we don't have enough in Sheffield, so I'm happy to pick that up with you outside the meeting, but physiotherapy and the assessment and therefore the rehabilitation is absolutely a key part of that offer in the home, so it will be a core component. We do have physiotherapy across different parts of the architecture as well. We have it out of primary care, and we have it, so it will come through that discussion as well. But I'm happy to take that action specifically outside if that's helpful. Thank you.
Thank you so much for presenting. And we're going to go on to the recommendations now. They are on page 58. So the recommendation is that we approve the Sheffield Place Hospital Discharge Model and Delivery Plan described in Appendix 1, that we note current performance in relation to discharge and progress in delivery, making change personal at Appendix 2, and request that the Strategic Director of Adult Care and Wellbeing provides the committee with update and progress against the delivery plan in March 24, and to review outcome of learning from phase 1 of implementation on future home care provision needed to sustain the new model. Are there any members who are not in agreement with that? Can we agree on that? Brilliant. Fab. So we move on to item 10, which is adult care and wellbeing governance assurance and performance framework, and I think Liam is presenting this. Thank you. Thanks, Ian.
Good morning all. So Liam Duggan, Assistant Director for Care Governance and Financial Inclusion, and this paper is to provide an update to the committee on an updated care governance strategy, performance management framework and cycle of assurance, and to give an update on the regulation of local authority and integrated care systems by the Care Quality Commission and the Council's preparations for this. So firstly, the care governance strategy. The original care governance strategy was approved by this committee last June, and it provides our overarching framework for the governance of all aspects of adult care and wellbeing services and support. It's been reviewed and updated to improve clarity, and there have been some changes to reflect the changing environment that we're in. Particularly a greater clarity around resilience, safety and safeguarding, but also a change to reflect the move away from a dedicated transformational change programme to ongoing improvement, and a stronger focus on legal governance as we prepare ourselves for CQC. The performance management framework also was originally approved by this committee last June. That too has been updated, largely following feedback from internal audit. We've now made a number of changes to that and added information in. We speak more in more detailed terms about how the cycle of improvement and the culture of continuous improvement needs to take place at each tier of the service, and how that will happen. We are clearer now about the CQC's regulatory framework, and so we've mapped that to our vision and strategy. We are providing more information about how we will monitor performance and being a little bit more prescriptive on the advice of internal audit, and we are setting out the outcome indicators that we are using to measure our performance against our vision and strategy. Lastly, the cycle of assurance, which was approved originally by committee in November, has now been updated to reflect and model the governance strategy. So the cycle of assurance maps against each of the domains in the governance strategy and shows how we will escalate routine reporting information through the service and ultimately to this committee in relation to all aspects of our governance framework. There are two types of reporting that will take place there. There's the routine reporting around things like performance and risk, and also updates on action plans and strategies that have been approved by this committee and need a regular follow-up. The key update around CQC is that since this committee last met, interim guidance has been issued about the CQC's proposed approach to regulating local authorities and integrated care systems, and the links for that guidance are in the document and are described in the paper at a reasonably high level. The Council's preparations for that CQC regulation are very closely aligned to the implementation of the governance arrangements that I've just spoken about earlier on in the paper. The initial immediate challenges around preparing a self-assessment paper for adult care and wellbeing, which is maintained on an ongoing basis, is accurate, reflects the views of people who use our services and the staff who deliver them. And we are currently putting together a second draft of that based on a lot of engagement and the activity of the performance clinics that have been taking place since last summer when the performance management framework was approved. We are also prioritising the embedding, as I mentioned, of the improvement life cycle taking place at each tier of the organisation, and particularly how those conversations connect to each other and in turn then connect to the self-assessment report that we're writing, so that it is a dynamic document and something that evolves as the service evolves and as our performance improves. We're doing a lot of work with individuals, carers, workforce and stakeholders, which is described in the plan, and with our partners with regard to system-wide readiness. I hope that provides sufficient information, but obviously happy to take questions.
Any questions? Councillor Rooney.
Yeah, it's me again. Sorry about this. I've often wondered how we follow, when we outsource a service to a private organisation, how do we follow up on their performance? Do we visit them? Do we, or what? What's the process? We used to do things like, I think we're Section 28 visits or something, they were called. A lot of my knowledge is out of date, as you can probably tell. But how do we follow up on organisations that we've subcontracted? To, and this is sort of anecdotal, but one of the criticisms I hear quite frequently from people who are suffering from antisocial behaviour by some individuals who have got either substance misuse or mental health issues, or a combination of both, is that the person that is supposed to be helping them get through their tenancy or everyday life simply knocks on the door, and when they don't get an answer, they walk away. You know, that's a regular complaint I get as a counsellor, that the person who is supposed to be being helped actually isn't, because the person who is supposed to be helping them just walks away at the first opportunity. They knock on the door, no answer, and away they go. How do we check up on that?
Thanks, Councillor Rooney. So, Catherine's joined me to help me with the response in relation to the following up on performance. But I guess from my perspective, initially, the purpose of the performance management framework that we're sharing today, the intention is that that will give sight to you and to us about the quality of our provision that is subcontracted. So that is the expectation and the design of the framework. The framework, the performance framework connects to two quality frameworks which were approved by this committee over the last 12 months. The care quality framework, which covers the quality of our services, much of which is subcontracted out, and practice quality framework. So the practice of our workers, social workers, occupational therapists, etc. And the secret to this performance management framework is ensuring that that connects to those quality frameworks, such that we get a flow of information from the front line, so that we all understand how we are performing and what the experience of people is who use our services. So that's the, if this performance management framework works, then we will have that assurance and we will have that view. Catherine knows is responsible for the care quality framework, and we'll have to talk a little bit more about that and the monitoring arrangements.
Hello everyone, I'm Catherine Bunton, the Assistant Director for Commissioning and Partnerships, which includes our Quality Assurance and Contract Management team. I always look scared, so, resting scared face. But with every new contract that we put out, every tender process, whenever something goes out to an external provider, there's absolutely a quality assurance and contract management framework that goes alongside that. And our team do lots of on-site visits, as well as collating information from complaints and from feedback. I think, as Liam said, we're developing stronger systems around that and stronger reporting. Absolutely, if a provider is going to somebody's home and they knock and there's no answer, that should come back instantly into adult social care, so we know, firstly for the well-being of that person, but also as part of our tracking about that provider and how often that happens. So that sort of information is tracked, and I think one of the things that we want to achieve over the next year is, in addition to being able to present and talk in quite a detailed way about how providers meet regulatory standards such as CQC and against our contract, really strengthening the feedback and our monitoring of people's experience of that care as an equal weighting against those CQC regulations.
Thank you. I have Councillor Smith and Councillor Milsom. Councillor Smith.
Am I on? Yes, thank you. So during the consultation, I'd like to know and understand that if there are any staff from the private sector, and I mean providers, private providers in the community, that there's a safe space for them to give their views about care in the community. So, you know, when the CQC do that, I'd like to be assured that, you know, if I'm a carer in the community and I think there's something that needs to change, that I've got the opportunity without losing my job to say so. But also I'd like to ask if you are speaking to carers, family carers, that are part of that. So important that if you're a family carer, that you've got access to give your views about the care that your loved one is having. I feel very passionate about that. And I really want to be assured that when we say we are doing the best we can to get good across the city for October, that that is absolutely possible. And I hope that that does include right to the bottom of the tree, the people who are giving the care. Do you understand what I'm asking? Thank you.
Thank you. Yeah, so the safety of staff to express themselves and to call things out when things are not as they should be is absolutely one of the elements that we need to be focused on. And we spoke yesterday about the possibility of setting up kind of champions for that, so that we are sharing policies and pathways, processes, so that people are aware of the protections that they have, and we are developing that sense of safety for people to speak out. So I think, you know, it's a really good call and something that we are actively looking at how we can strengthen. In terms of the family carers, we've got a festival of involvement taking place this summer, where we are looking to engage a wider group of people who encounter our services, carers, people who use the services directly, and we are having initially a series of pilots to talk to them about our vision and strategy, and how they think we're getting on, and what our performance information means to them, and how they interpret it, and what feedback they give to us on the back of that. And then from September, October, using the learning from that, we are looking to co-produce longer term arrangements by which we will routinely meet with people who use services, including carers, to review our performance information, our data, and to use that to improve our services.
Thank you. Councillor Milson.
Thank you very much, Chair. Yeah. I just wanted to comment about the Festival of Involvement, and I did attend the launch event, and I'm hoping to get along to some more events as well. And I think that's obviously a really good thing, and it's, you know, we've talked about co-production and we've heard multiple reports about co-production, and now it's you know, there's a whole festival of co-production, so that's really good. I did note, though, at that first event that the intention was to open up a discussion about how involvement can be improved, and you know, the idea was that people with lived experience and carers and families would all be involved in improving involvement. Sort of a kind of a Russian doll kind of thing, isn't it? But at that event, there were some people had come just wanting to air grievances, and that was noted, you know, at the event as being not a diversion from this discussion, but an important part of the discussion. So that was that. I think that's worth noting, that you're wanting to go ahead with, you know, improvement, but actually people are still stuck at the point of needing to get a grievance out, and that to ensure that there are suitable channels for those discussions within that festival of involvement, if that's the point of access that people are coming at. So that's more a comment, really. But I wanted to just ask about the co-production working group that's going to follow on from that festival involvement. So September, October, I believe there's going to be an involvement, a working group, to develop an involvement model for adult social care. I just wanted to ask about the recruitment process to that, because there was a sign-up form, but obviously that's a pretty loose way to get recruits to that working group. So how is that going to be fully representative, that group, and recruited to? And in that, I just wanted to mention the Race Equality Commission. That is, I think we're now sort of on the 1-year anniversary of that Race Equality Commission that took place in Sheffield, and there has been a report and recommendations. But personally, I'm not seeing those recommendations and actions from that commission coming through in council reports. So although there are equalities impact assessments and so on, I'm not seeing any specific mention of those actions from the Race Equality Commission. So, and I think it's worth looking at actions 2 and 3, which are all about making sure that all the right voices are involved in this kind of involvement exercise. Thanks.
Thanks, Councillor Wilson. So, in terms of the co-production working group and the sign-up process, I know there's been an awful lot of publicity and marketing, and a lot of interest from a diverse group of people. I can't tell you off the top of my head what the sign-up process is, but I can let the committee know, and I'm sorry about that. In terms of the race equality report, equally that's a piece of work we're doing a great deal of work on at the moment. There's quite a few new things being progressed, and we are planning on bringing a dedicated item to this committee. I think it's next time, September we'll be providing a formal update on that.
Yeah, I can't help commenting at this point on the irony of even mentioning that, looking at the people in this room. I don't mean to be, down on this, but this is an incredibly white middle class room. And we're discussing the need for involvement of people who aren't in this room. So I just really wanted to put my finger on that today. Thanks.
Thank you. And being the BAME person in the room, I'm gonna agree with that, which is, ridiculous if you look at me. So yes, and I've raised similar points I did like a New Year's resolution where I was raising the Race Equality Committee in every meeting I went to, and I did it consistently for 4 months because, yes, thank you very much. So we have 4 recommendations from this report. They are on page 75 of the printed papers. The first one is approve the updated care governance strategy 23-25, approve the updated performance management framework, approve the updated cycle of assurance, and finally note the council's preparation for CQC regulation and key risks. Are members in agreement that we can agree those? Brilliant, thank you very much. We are on to item 11, which I think is Catherine.
Hi, yes, thank you. So this report provides the committee with an update on the commissioning activity that was undertaken last year, particularly with progress in meeting our Care Act duties as they relate to securing a sustainable market. Committees asked to approve the commissioning plan that's in Appendix 1, again very sustainable market focused, to approve the process for care fees in 24-25, and to note the extension of the Care at Night service. As you read through the report, it's relatively short, I think, in comparison to some of the others. Section 1 is largely about what we've done and what we plan to do this year. And then section 2 is about the care fees process. So I think it's worth noting that our new contracts for home care, supported living day activities and short breaks or respite, within those contracts we've set out how our fees will be uplifted annually. and so all commission providers on those contracts know that. For residential, we're going to undertake a further cost of care exercise around non-standard provision to supplement the cost of care exercise we did last year around standard and EMI provision, elderly mentally infirm, that is, sorry. And also undertake a consultation which will inform our fees proposed for 24-25. The key thing that we want to do for the benefit of both the council and our providers is bring that forward. So last year our proposed fees came to committee in March, I think, and we want to bring that right forward to November, which sends a much better message to the market and helps them with their own financial planning. And it will tie in, of course, with our residential commissioning programme, which is also due to come to committee in November. Nice alignment there for the agenda. And then in section 3, that's just asking committee to note please the extension of the care at night contract. We commissioned that jointly with the ICB, who are chairing and leading a task and finish group on new contractual arrangements, which will be in place by April next year.
Thanks, Catherine. Are there any questions? Wow. So,
Hi, thank you. So I'm aware this might have been discussed before, but I'm a new committee member, so I've got a quick question. How do we ensure that we have a good and attractive local offer which encourages buy-in to our vision from the private providers, but at the same time provides value for money and is affordable, I guess? So what buy-in do we have already from them sort of with regards to that? Thanks.
Thanks. So in terms of being an attractive city for providers, and a good local offer, the working age framework was a really strong process and good example of how we did that. There was a lot of engagement across the sector in the development of the specification and with people with lived experience using it to make sure we were asking for the right services, getting the variety we need, working very closely with our direct payment improvement programme to get that real variety of provision so that we can be as personalised as possible in terms of the care that people want to receive. And in terms of the value for money, I definitely think the cost of care exercise helped with that. We formally had to do it through a central government directive with our home care providers and our over 65 residential providers. But actually the exercise brings out lots of information that is very relevant for supported living and other similar provisions. So we did use that information in considering appropriate fee rates and value for money, and certainly for day activities our providers were able to come with their pricing schedule as part of the tender exercise, which really helped to reset some of that and make sure that the market was sustainable in it and it was attractive. There's obviously, it's not a finite process. You have to keep going. You have to have that engagement, those relationships, and be ready to be adaptable and change with new people coming to the city as well.
Thanks, Catherine. We've got a few questions actually. I have Councillor Arias.
Sorry, on page 144, I see that the only one that stands out, other than the amber, is the review appointeship requirements not started. So I imagine there are sort of legal and safeguarding complexities, but do we have a time scale for the review to happen?
Yeah, we are hoping to do it by the autumn of this year. It's just an honest thing that it hasn't started yet, and it's not to say that there aren't any appointeeship arrangements. There are, and in fact the council offers some as well, so it's more about making sure that we've also got choice within the market.
Thank you. And on page 146, on the slide, where it talks about, I'm glad to see that that phrase is co-produced with design learning and training opportunities for PA co-produced with individual employers and PAs, which is something that I think we've sort of thought of as a priority previously. Hopefully that will be outcome focused and person-centred rather than time and task. So I think it's a comment really. I think it would be good for policy committee members to follow progress on this, particularly as the report says PA is the most popular use of direct payments but are difficult to recruit. So I'm just suggesting that that's something that policy committee ought to follow. Thank you, Chair.
Thank you. Councillor Rooney. Councillor Milsom first and then Councillor Rooney.
Thank you very much. I'm just interested in 6.4 in the report, in the climate implications, and it's more a comment really and a suggestion that as well as looking at travel and energy efficiency and using low carbon energy and so on, which is mentioned here, that this sector might also be looking at food and sustainable food sources, so locally sourced food, growing food, and recycling food waste, and things like offering waste for animal feed and so on. So I just wanted to highlight that in that part of the report because it's not specifically mentioned.
Thank you. And I think we are looking at our kind of climate assessments, aren't we, as a directorate in general? So yeah, we can maybe do like a working group or something on that, on how to address that, so that it's easier for officers to think about it. Thank you. And Councillor Rooney.
Thank you, Chair. It was, I may be going off on a bit of a tangent here, so I apologise if I am, but it's something Steve said about personal budgets. What is the process, for example, for in terms of uplifts to those budgets, and what do we do in terms of our charging policy these days in terms of uplifts to that, and also to disability related expenditure? How do we deal with that?
Thanks, Catherine.
So I can take the uplift question, so that will be in the report that comes in November as well and was in our March report. So it's slightly nuanced in personal budgets because of the different ways that people might receive them, but everybody gets an uplift connected to it, and last year, as with previous years, it's linked to modelling around inflation and wage increases, or national minimum wage. The charging policy, actually we'll be reviewing that as part of our home care recommissioning as well, but I think it was reviewed maybe in 21-22 actually, slightly before my time.
And mine.
Yeah, but we could certainly come back to committee with more answers on that. Similarly, I wouldn't have the answer right now about the disability related expenditure to hand, but we can definitely come back on that.
So we have a process. Yeah, that's all I wanted to know.
There'll always be a process.
All right, thank you.
Thank you. Can we have those answers sent to the committee? Maybe in one of the briefings, it could be with, it doesn't need to be long, it could be bullet points, and it's, brilliant, thank you. So we're going to go on to the recommendations that are on page 124. Number one is note progress made in relation to providing support in the city and delivering a stable care market. 2, approve adult commissioning plan for 23-25 attached at Appendix 1. Approve process for care fees, business planning, and process for consultation and on care fees for residential services for the financial year 24-25. And finally, note the extension of the current care at night service until March 2024. Are members happy to approve those? Brilliant. Thank you. And we go on to item 12. Which I believe, it's John. Thanks.
Afternoon. So this is a brief report, and given it's a brief report, it will be a brief presentation of that report on the development of the Care and Wellbeing Directorate plan. As you know, we have had the Adult Health and Social Care Strategy, Living the Life You Want to Live, in place for just over a year now, along with a delivery plan that the committee approved at its first meeting last year and has been updated and was updated in the spring. The Directorate plan is the next level of detail beneath that, or will provide the next level of detail beneath it, with a shorter timeline, so a 1 year or so focus, and feeds into the development and delivery of the Council's corporate plan, which is under development, and you'll have heard about in other places linked to the city goals. So there's a big strategic framework, and this is the point where it gets tangible on a shorter horizon. We are going to be developing that over the summer, and this report sets out the approach towards doing that. We will, I'm just going to briefly highlight a couple of elements of that approach. And the report also talks about lots of the achievements from effectively last year's Directorate plan, which was set out as part of the delivery plan because it was the near horizon. And there's a list in 1.4.5, paragraph 1.4.5 of those things. I won't read them out to you now, but there's some big stuff over the last year. There is a festival involvement going on at the moment. In fact, there was by the sounds of it, a really successful event yesterday as part of that. And we want to use that feedback in the development of the year's development plan. We also, obviously, this is the first meeting of the new committee membership, and we want to spend some time with you listening to your priorities. And we've got some away day time to do that and help you feed it. And there's some elements of the joint strategic needs assessment, which is effectively the master data set for data about our population, along with some specific stuff actually about racial equality, Councillor Milsom, that we want to feed into this as well. So the plan is that we would spend some time bringing together those various sources of information over the summer, and it will come back to this committee at its September meeting for hopefully approval, but certainly your comment and amendment if you wish. Specific to a couple of questions that have been raised in other items, that will include effectively our approach around equalities, but with a specific focus on racial equality, not least because of the Racial Equality Commission stuff, and very interesting meetings even yesterday around how we progress that, including with a member of the Racial Equality Commission. The other element that's been mentioned so far is around climate, and we will have an appendices direct plan around certainly our initial work around climate, although there is so much more to do that, and the sophistication of that work will need to continue over the months and years ahead. So, Chair, I suggest I leave it there, but I'm happy to take any questions your colleagues have.
Are there any questions? Okay, so we are asked. Sorry.
Sorry, just one question, very specific. So obviously there's lots of strands to this, but specifically under Adults Workforce Strategy and Delivery Plan, is there still an active pursuance there to attain we've mentioned the Unison and GMB charters today. Is there still an active pursuance to reach those foundation living wage levels? That I know last year the committee agreed to pursue that actively. Is that built in?
The committee, absolutely. I mean, as the committee's decision, it is set out in our long-term plans. The question is how we incrementally get there, and that is obviously. I mean, Catherine is a far more expert on the fee setting as we've been talking about, but absolutely would expect that to be something we would actively work towards. We'll talk in Alexis' desk report, which I'll support on any details on shortly. There's a bit of a section on some of the workforce developments, and there's some around care pathway that the government has called for evidence on around some of the publications recently. So I'd expect there to be a big focus on workforce terms and conditions over the next couple of years, both locally and nationally, which of course will update you. And one of the things we've been doing is putting extra capacity in, I think imminently at the assistant director level to be announced. But certainly we appointed a service manager dedicated to our external workforce earlier this week, and I'm delighted. We had a really strong field, and we're delighted with the person who's accepted the job. And we'll be putting more resource than we ever have before into supporting our external workforce, and actually a lot more than a lot of our colleagues does, which is something we have the luxury of being able to do as a large authority with economy of scale here. And we're working very closely across the health system on the Sheffield footprint and actually the social care community across South Yorkshire to really push on this. It's important. We've heard that it's important to you. It would anyway be important to Alexis and me and the rest of the team. And it's something, it's 90% of people, 95% of people experience of care once they're in the care system is working with people in the externally provided workforce, and that's who they see day to day. We need to treat those people properly, and we hope that we do, but we want to increasingly treat them better, value them, and make them more integral part of it. We'll talk more about this in the coming months, and as you can tell, I will talk as much as you want to about it outside here.
Chair is going to stop you there. Can we have a look at the recommendations on page 168? The first one is endorse the proposal and approach to developing a refreshed strategy delivery plan and a company adult care directorate plan for 2023-2025 for approval at September 2023 committee. So we're just endorsing for it to come to September, endorse the review of the joint strategic needs assessment, workforce planning, performance data, equality, impact assessment and climate impact assessment are undertaken through the summer period and inform a refresh of the plans. Do we agree on those? Brilliant, thank you, John. And we go on to item 13. Councillor Smith, did you want to say something? Thank you. Thanks, Liam.
Apologies. So thank you, Chair. This paper is a regular report to provide an update about adult care and wellbeing financial position, an overview of the budget, and to seek endorsement for our recovery plans. Table 1 in the paper describes the funding for the adult care and wellbeing service. We can see in the table that the gross budget's increased by nearly £19 million this year. That's almost all to do with increased levels of grant and income, but has to be seen in the context of £31 million of the additional cost pressures that we were looking at in business planning last year. The total budget of £293 million includes £134 million of the council's cash limit budget, so cash limit now being 46% of the adult care and wellbeing total budget. The table describes the other lines, including the second most significant contribution to the budget being through fees and charges, which includes the charges paid by citizens of Sheffield and the contributions to direct care paid by the NHS. There is also income from the Better Care Fund and through the Section 75 agreement, which is from the NHS and includes Better Care Fund grant that the ICB passports to the local authority. The most significant increase in the budget then we can see is through the Adult Social Care Grant, which follows the National Fair Cost of Care exercise and includes Market Sustainability and Improvement Fund, to increase rates paid to third-party providers and other grant income which was required to meet national living wage levels and the levels of inflation that we saw coming into this year. Use of resources is described in Table 3. We can see most spend is on third-party provision, and nearly all of that is through our purchasing budgets, and the table 4 shows how that purchasing is allocated between the different groups of people and support types. And Table 5 shows how the levels of contribution that are made by individuals affects the net budgets and the net cost of the services to the council. It's important to remember as we go into CQC regulation that these budgets are funding the council's Care Act duties, against which we will be regulated from September. And we've included the CQC theme against the Care Act duties as well, just to show how this spend maps across to some of the other work that we've been talking about, particularly my last paper around CQC readiness. Table 7 then is showing how the net budgets compare last year to this year. This includes the temporary net budgets and one-off funding that occurred to this year. So there's a slight discrepancy between Table 1 and Table 7. But we can see that last year, and I think Jane's going to talk us through that next, we reduced the variance to a relatively low level because of a significant amount of one-off funding that came through from particularly from the NHS towards the end of the financial year last year. But we can see, looking ahead, it's going to be another challenging year for adult health and social care, with £19 million worth of new savings to deliver, 5 million thereabouts of slip savings from last year to deliver this year. We have an underlying pressure in learning disabilities, which we are actively planning to mitigate, plus other pressures coming through, not least staffing pressures to ensure we are able to prioritise the reviews to deliver these savings, to support discharge, as we've spoken about earlier, and other risks. For example, the liberty protection safeguards now not being implemented, which means that we need to look at how we work through our mental capacity assessments in a different way. The Appendix 2 describes our savings and provides an update on progress with those. And we can see in Table 8 how they form part of the overarching picture of how our pressures for this year have been met. £19 million worth of which is through savings and £13 million through grant. The removal of one-off funding from reserves this year has been offset by the increase in the social care precept.
Thanks, Liam. Councillor Rooney.
Yeah, I think Liam, when you're talking about these sorts of issues, there's a lot of new people in this room, and there's a lot of the collective memory has gone with those that aren't on this committee anymore. So for a lot of us, this is a brave new world and very confusing. And I particularly struggle with figures. So when you're going through or compiling these sorts of reports, I think you need to bear in mind that we are not accountants or finance officers, and just don't assume that we know what you're talking about. I'm not you know, I'm not having a go, I'm just trying to make it so that the people in this room and you understand the decisions that we're going to be asked to make and the finances behind them. I mean, Section 75, how many people in this room know what that is? I used to, because we used to have one with the Care Trust. But whether it's the same thing now, I don't know. So I think you also have to remember that we're on the telly as well. So there will be people listening to what you're saying and wondering, what on earth is he on about? Because some people do actually take interest in some of these committee meetings. So you've got not only the audience in here, but you've got an audience out there as well. So just please don't take it for granted.
Thank you, Councillor Rooney. Can I respond to that? Because we've had this conversation already. So there is some training coming up for non-financial minded councillors, and we were given a pack in terms of the jargon and the various things. So there will be sessions. I think it's not the time to kind of have a discussion with an officer during the meeting about the jargon. Let's concentrate on the report in terms of, because this is just the picture and the work ahead for the year, basically. It's just the numbers as they are, as they've been set up in the budget that we all agreed on in March, and just how we're going to move forward. So the positions will change during the year. And thank you, Liam. I think what you will also find is that it will become really familiar, because, for example, for me, having been on the committee, I have questions when I see the table, and then I read and I can see my answer is already there. So it will become better. The beginning is quite overwhelming. It's a massive portfolio, and I really kind of remember being in your position last year. So really appreciate the comment. But are there any questions? So Section 75, do you want to say what it is, Liam? Just to clarify, thank you.
Yeah, the Section 75 agreement will be the same. It's the provision that we have to share resources where there's an overlap between health and care delivery, and what's in the Section 75 agreement is updated and reviewed each year to reflect the changing partnership arrangements between us and the NHS. And there'll be separate items on Section 75 of the Better Care Fund.
Thank you. If there are no further... Oh, sorry, Councillor Phipps.
Thanks, Chair. Just to confirm, when we're talking about the savings, was it 18 million? And I noted that there's a spreadsheet with, I think, savings attached to it. Are these going to go through... Are these savings that we've already approved last year for this year? Yeah. Or is it a combination with also approving additional savings in this year in the same format?
So, thanks. These are the savings that were approved by this committee last year for this year, and now we're describing progress in delivering them.
So the recommendations are on page 178, and just a little correction of an error. I think in the recommendation 3, it should say the 26th of July, because the 23rd is a Sunday for that workshop. But I know that date is being looked at anyway. So I knew it was Sunday because I'm doing something on that day, so it jumped. So the recommendation are: note and consider the adult care budget in totality, pressures and current progress with the recovery plan alongside the legal requirement which the local authority is required to meet in relation to adult care and evidence of forthcoming CQC assurance. Number 2, note the ongoing annual pressures exceeded the Council's ability to increase funding for adult care. 3, note the workshop will be held with committee members on business planning for 24-25 budget, to be held at the moment is the 26th of July 23, and detailed review of the adult health and social care budget's income, spend and pressure, to be held on the 12th of September. Note that an independent look at adult care services will be undertaken to address budget pressures and propose mitigating actions. Are we all happy with those being noted for us going forward? Thank you, and thank you, Leon. Now, we've got less than 20 minutes. I am quite happy to say that we're going to finish on time, or I can ask you to vote on extending the meeting by 30 minutes. You know what you need to do to finish on time, don't you, members? Okay, thank you, Jane. Will you take us over item 14? Thank you very much.
Thank you, Chair. My name is Jane Wilby, I'm Head of Accounting, so I'm here today to bring the report, which is the final outturn position for the Council for 22-23. So the headlines really are that the Council overspent the General Fund by 5 million against net budget of 450 million. That meant we had an unplanned draw from reserves to meet the year-end deficit. So in 21-22, we identified a 70 million risk reserve to manage the delivery of our budget savings. So we used 20 million in 21-22. We used 15 million when we set the budget in 22-23. So actually drawing 5 to cover the deficit this year really means like another 20 million draw from that reserve, which leaves us a 30 million risk reserve as we move into 23-24 to look at delivery of the budget this year. So the closing position did improve significantly throughout the year. We started with an overspend of over 20 million at the beginning of the year, and we brought that down to just 5 million. So the table on page 198 of your pack shows the improvement from each of the different months and which committee budgets contributed mainly towards the improvement. So it was good to note that the Adult Social Care Committee did contribute a 6 million improvement towards the budget position, and that was mainly due to additional funding we were able to lever in towards the end of the year from the winter discharge funding. The Transport, Regen and Climate Committee improved by 2.5 million. Some of that was due to a mitigation of an unachievable saving in that committee. The Strategy and Resources Committee improved by 4.5 million. A lot of that was due to income from investments. We had some favourable economic conditions that meant that we got a lot more interest income into the council. There was also slippage in the capital programme, and we had additional funding from the business rate levy surplus into that budget area. So the main reasons for the overspends with the council overall were the shortfalls in the budget implementation plans. So we had 19.5 million not delivered last year. We did have some one-off mitigations to offset some of those delivery challenges in year and the inflationary impact that we did see. So in page 199, I talk about the energy prices and sort of what the impact of that was last year. So we had an additional £5 million on our energy bill last year, which was a huge amount to be covering, which we drew down from provisions that we'd accounted for in previous periods in anticipation for that. So the main committee overspends were 5.7 million in adults and 5.8 in children's. So the issues in children's were to do with the residential strategy and also transport costs and increasing placement costs in the year. We also had an issue in the housing revenue account last year due to quite a significant backlog in repairs, additional disrepair claims, and also loss of rent from the vacant properties that we have in our stock. So on to the adult social care. So we overspent at 5.7 million against a net budget of 151 million. The challenges really were about delivering those budget targets last year. There was 25.2 million to deliver, and we were reporting that we delivered 16.5 million of that. We've continued to have issues in our purchasing budgets, particularly in learning disabilities, which remains a key risk for the committee to note. Service does intend to respond to these challenges this year by continuing reviewing the high cost package increases to understand the cost drivers underlying, completing value for money exercises for services which have got above inflation increases, and looking at how we can shape the market to increase options for day services, respite and accommodation. The other pressures that we've got, of course, are to the staffing to deliver those savings. We did see the older people's budget stabilise towards the end of the year with more encouraging trends in the cost of home care, which is the costs were coming through at a more sustainable level. So the upside really in the budget was an additional 6 million that we had throughout the year, and this was mainly due to the additional funding that the service received following the announcement of the Winter Discharge Fund in autumn 22. Council colleagues in finance and adult social care have worked diligently with our health colleagues to ensure that we've maximised the eligibility to draw from that funding. So Liam's paper talks about the savings targets that we've got for this year and how we intend to deliver them, and it will be a challenging year ahead for the Adult Social Care Committee. Thank you. If anybody's got any questions, I'm happy to take.
Thank you. Just going to remind members, we're just noting what's happened last year, basically, and acknowledging the challenge ahead. And I have questions, but it's more notes for us in the committee, you know, when we're planning things. So thank you very much, Jane, for that. So the recommendation is to note the updated information and management actions provided by the report on the 2022-23 revenue budget outturn. All happy? Brill. And we are on the last item. Alexis, you have 2 minutes.
So, John and I are going to do a bit of a double act, so I'm going to do it very quickly due to the time. This report basically is our DAS highlight report, and every committee what I do is provide a highlight report to members on what we've achieved and delivered so far, particularly against our strategy outcomes, but also the impact we're having on people. And what is good to see, and I'm going to say this, is that we are really delivering upon all the things that we said we would do in terms of the strategy we are delivering. And particularly, it comes back to the point as we know about direct payments and PAs. We had a wonderful event 2 or 3 weeks ago in which we talked about reshaping our personal care market and particularly how we recruit and retain more PAs, and particularly focusing on direct payments. That's been well received, and now we're going to be bringing annual reports and updates to members around that. Equally, we had a wonderful technology-enabled care event a couple of weeks ago, and we had over 200 people attend our event. What that's led to is us going to be hosting now is a national conference around technology-enabled care in September, which is really great from the point of Sheffield, because it actually highlights not only the positive things that we are doing, but when you think about some of the budget challenges we talked about earlier on, is actually how we're working innovatively and differently to start to tackle some of the longer-term challenges that we have together in a very different way. So.
Given the time constraints, I'm happy to leave it there, but I'm here in case there are specific questions on some of the content of the report.
In terms of new members, so what the DAS report does is like give us, you know, a picture of what's happening, what has happened, what we're doing, and then if there are any updates that we've asked for during the course of the previous year. So, for example, some of the items today, it says it will come back to committee with an update. If it is a short update, it will go in this report rather than having another report presented. It's just to make it more, you know, effective and quick. So, are there any questions on that, or are people just happy? Do you want to say anything else, Alexis? All we ask to do is to note the Strategic Director of Adult Care and Wellbeing report. Are we all happy with that? So I can now say that we are finishing this meeting at 12:22, 8 minutes to go. So thank you very much, members, and a huge thank you to the officers who've attended. Thank you.
Thank you, Chair, and congratulations at chairing an excellent meeting. Thank you.